Hello, everybody. The topic for my presentation for this conference is Management of Stage 4 CA Temporal Bone and the Review of Literature. Stage 1 to 3 CA Temporal Bone has usually a good outcome in majority of the patients, but Stage 4 lesions have a treatment protocol which varies across the world since many decades because there are many multiple factors which make the management very difficult and complications very probable, like intracranial extension, involvement of the great vessels like internal carotid artery or neural involvement like facial nerve. The anticipated complications also influence the final treatment plan in addition to the prognosis. So a good quality of life requires preservation of central function as in the brain, hearing, internal carotid artery, swallowing and speech function, and facial nerve function. Methodology. So we did a retrospective review of the patients operated in our department in All India Institute of AIIMS, Bhubaneswar, India, for stage 4 CA temporal bone cases from June 2014 to December 2017. A total of 21 patients were recruited in our study because our institute belongs to Eastern India, where not many centers are performing such surgery. So we got a huge number of cases in that short period of time. All the patients were treated with surgery followed by chemoradiotherapy. So the structures involved preoperatively were facial nerve in 9 patients, dural invasion was there in 11 patients, petrous bone involvement with cochlear erosion in 6 patients, parotid gland involvement in 8 patients, which may be stromal involvement or the involvement of parotid lymph nodes. Carotid canal erosion with more than 180-degree encasement was seen in 3 patients and less than 180-degree was seen in 2 patients. That actually makes a difference. We'll see that later. Jugular foramen involvement was there in 1 patient. So these are a few pictures. So this patient had a huge CA temporal bone involving the intracranial region and also the infratemporal fossa. Here we can see the infratemporal fossa involvement and also dural invasion is seen here. Post-operative scans showed disease clearance, and for reconstruction, a posterior scalp rotation flap was done. Because of the CSF leak which occurred post-operatively and also intraoperatively, a lumbar drain was inserted. So the surgeries performed were most commonly lateral temporal bone resection. The point to be noted here is we have, in all the cases, we have performed a superficial parotidectomy at least, or maybe a total conservative parotidectomy if parotid gland was frankly involved. And also a supra-omohyoid neck dissection was done in all the cases. So the most commonly done was lateral temporal bone resection in 10 patients. 7 patients underwent subtotal temporal bone resection, and a modified lateral temporal bone resection with sparing of internal carotid artery was done in 3 patients. Sleeve resection was done in 1 patient because of limited disease which was there intraoperatively. 1 case had to be abandoned, unfortunately, due to internal carotid artery injury, for which suturing was done and the bleeding had to be controlled without any neurological sequelae, thankfully. So all the patients received post-operative radiotherapy of 30 fractions and 60 degrees over a period of 6 to 9 weeks. Interrupted radiotherapy was there in 3 cases because of toxic reactions which the patient developed. In 5 patients, a positive margin in 5 patients with positive margins, a concurrent chemotherapy was also administered. So this is the patient profile. The total 21 patients were there. The first 10 patients which we received. Not going into the details, I'm just showing you the factors which we took into when doing the analysis. So margin positivity, ICA involvement, dural invasion, preoperative and intraoperative facial nerve palsy, nodal involvement, which involved the neck nodes and also parotid nodes. So I have mentioned the intraparotid lymph node involvement separately. This is the outcome, death or recurrence. So then these are the next 11 patients, so 21 patients. Going into the summary in the next slides. So coming into the results, the average age was 58 years. 57% patients were male. Unexpectedly, a higher proportion of females were actually seen. Literature shows that CA temporal bone usually occurs in males more than females. Internal carotid artery involvement was present in 5 cases. A margin positivity was seen in 8 cases out of 21. Dural involvement was there in 8 cases, and a pre-op facial nerve palsy was present in 4 cases out of 21. Intraoperative facial nerve injury was there in 5 patients. Positive lymph nodes were there in 7 patients, and out of those 7 patients, 3 patients had a internal intraparotid lymph node positivity. So the lymph node positivity was seen in histopathology, of course. Blood loss average was 600 ml to 1700 ml, the range. The average was 784 ml. Average hospital stay was 11.5 days, and one patient had to stay for a month because of wound-related complications. A positive margin was there in 8 patients. So the complications which were encountered, most commonly a swallowing difficulty was seen in 5 patients. 3 patients developed post-operative facial palsy, which was not there preoperatively. CSF ataria occurred in 3 patients, and the same patients also had meningitis. Skin necrosis or wound infection was there in 2 patients, and internal carotid artery injury, as mentioned before, occurred in 1 patient intraoperatively. So here the Kaplan-Meier analysis shows the death event. So 4 patients succumbed to the disease. 1 patient had more than 180-degree encasement, which was there in 3 patients. So out of those 3 patients, 1 patient succumbed within 6 months of the disease. There was a very sudden recurrence. There was a recurrence, and the patients succumbed in 6 months. And later on, after 2 years, we had 3 more casualties, which were disease related. So the mean duration of follow-up in our study is 59 months. And at 60 months, the death-free survival was 80.2%, as in 17 patients out of 21 had survived for 5 years. So recurrence, the same patient who succumbed within 6 months had a recurrence, and 5 more cases had recurrence at various periods of follow-up. So 6 cases of recurrence were there, and at 5-year period, 60 months, recurrence-free survival was 68.8%. So yeah, so the recurrence of the disease at various stages and the deaths also are mentioned here. So 3 cases with internal carotid artery involvement more than 180-degree had a disease recurrence and death within 1 year. 8 patients had a parotid gland involvement. 7 had a positive nodal disease, with 4 having intra-parotid lymph node positive, and 1 patient died within 3 months. So carotid canal involvement was there in 3 cases, more than 180-degree. Out of these 3 cases I mentioned, I've shown the slide imaging here. So we can see the involvement of the horizontal segment of internal carotid artery. These are the post-operative scans. Unfortunately, the patient had a recurrence within 6 months and recurrence within 1 year, and the patient died due to the disease. This is the mentioned patient. Another patient with intracranial extension, which was very extensive. The patient was operated, and CSF leak was there. Patch duroplasty was done, and fortunately, the patient survived. So, in our experience, internal carotid artery involvement of more than 180-degree is a very bad prognostic factor, and intracranial involvement or dural invasion is not at all a contraindication for surgery and usually has good prognosis. So, disease clearance may be done with the dura repair. So, this is one example of this case. So correlating the various variables, as I mentioned before, with death. So internal carotid artery involvement was there in 5 cases, and out of these 5, 3 cases had succumbed to the disease. Dural invasion was present in 8 cases. Only 1 patient succumbed out of those, and 7 patients survived. Intraoperative facial nerve injury was there in 5 cases. Only 1 case succumbed to the disease. Preoperative facial nerve palsy was also there in 4 cases, and it was not related to death or high risk of death, as seen here. A margin positivity. So it has an equivocal result. 4 cases out of 8 survived, and 4 did not survive. Lymph node involvement again. Unexpectedly, any patients with the lymph node involvement did not succumb to the disease, and all of them survived. Total 7 of them are there. So coming to recurrence. Internal carotid artery involvement more than 180-degree was there in 3 cases, and out of 5, all of the 3 cases had a disease recurrence, which is a very significant point to be noted. Dural invasion was there in 8 cases, and similar to death, only 1 case had a disease recurrence. Intrafacial nerve injury was there in 5 cases, only 2 had a recurrence. Prefacial nerve palsy in 4 cases, and 1 had a recurrence. So again, margin positivity has similar results. 4 patients had disease recurrence out of the 8 patients. And lymph node involvement was there in 7 cases, out of which 2 had a recurrence. So what we can infer from here till now is internal carotid artery involvement more than 180 degrees should be taken as a as a bad prognostic factor, and a margin positive excision or dural invasion should not be a contraindication to surgery, even if R0 resection cannot be done, even if the disease involves the intracranial portion. It should not be an contraindication for surgery, and the patient usually has a good outcome as per our experience. So, because the values were not that high, Fisher exact test was used for analysis instead of chi-square, and p-values were calculated. So we have seen the relation proportion wise, but p-values were not significant for any values, and even internal carotid artery involvement was not a significant factor for disease and for death and recurrence. The p-value being more than 0.05, alpha was kept to 0.05. Similarly, margin positive excision, dural involvement, pre-facial nerve palsy, intra-facial nerve palsy, lymph node involvement, and intraparotid lymph node involvement were not significant factors, taking into account the value of p-value more than 0.05. Further studies with a larger sample size or a meta-analysis may be a better approach for calculating the exact values of significance. So coming to the discussion, so we also did a review of literature for the past 5 years. All the original articles, which are prospective or a retrospective series. One second, yeah. All the articles published within the past 5 years from 2015 to June 2021 were taken, which are prospective or retrospective studies, which have studied the prognostic variables like we did in our study. So I will be just going through the negative prognostic factors which they have mentioned, and the factors which the study said that are not significant. So negative prognostic factor in almost all the studies, advanced stage is taken as a bad prognostic factor. We just analyze the factors for stage 4, but expectedly a stage 3 or 4 disease will have a bad prognosis in comparison to stage 1 or 2. So Mario et al. Conducted the study in 2015, and they said that dura involvement is indeed a bad prognostic factor, which is unlike our results. Regional lymph node metastasis was told as a bad prognosis factor by De Silva. Omar et al. Told a dural invasion or a temporomandibular joint invasion is also a bad prognostic factor. Advanced age and prognostic and positive margins were told as bad prognostic factors by Viersbika et al. And Suna et al. Told that history of previous irradiation is a bad or a negative prognostic factor. Again, positive surgical margin was told to be a negative prognostic factor by Matoba et al. 2018. And Nemeth et al. Told that only the advanced stage is a negative prognostic factor, and factors like age, sex, facial palsy, pathological grade, dissection margins, and adjuvant CTRT. All of these are not any significant factors. So Millman et al. Told a nodal involvement or a margin positivity is a bad prognostic factor. Further studies which we analyzed. So the point to be noted is that all the studies have mentioned different factors to be negative prognostic factors. The commonest being, of course, the stage of the disease. But many studies have mentioned nodal involvement or dural involvement as a negative prognostic factors, and many studies have said the opposite. We right now are presenting our results. Yeah, so other studies also. Peras et al. Mentioned in 2020 that involvement of mastoid, facial nerve palsy, involvement of middle ear, basically the stage of the disease is a negative prognostic factor. So, concluding the presentation, a total temporal bone resection has an immense morbidity, and the effectivity is quite questionable in the long run. So we have performed lateral temporal bone resection or subtotal temporal bone resection only. The comorbidities which come with a total temporal bone resection significantly outweigh the benefit that the patient gets. Also, the morbidity is significantly decreased with preservation of ICA and lower cranial nerves. So if intracranial involvement, internal carotid artery involvement is there in the patient, then the disease should be left around that, and internal carotid artery should not be injured anyhow. And lower cranial nerves should also be preserved, like facial nerve. The usage of good adjuvant radiotherapy or chemotherapy is a major prognostic factor, according to our results. The 2-year disease-free survival has significantly improved with better tumor visualization and improved RT techniques. Preservation of lower cranial nerves and IC again, they do improve the quality of life. So more than 180-degree involvement of ICA, internal carotid artery, with carotid canal erosion is an contraindication for surgery, and prophylactic neck dissection and peritoneectomy should be a routine according to our series. That is our main result. But this obviously needs to be evaluated with a larger sample size. Thank you very much. This was all.
Okay, that's thanks, Dr. Yash, even you're not here. And I think it's will be a good opportunity if anyone have any question to get his email. So excuse me, Alexandra, if you can put his email so the candidate can send him any question regarding his presentation.
Sure,
if they
sure,
want
Dr. Amida.
neck tumors.
I'll put it in chat box.
Yes. And I hope that Professor Mashodo get your support and he get the tips how to open this PowerPoint and share the screen. So now I will welcome again Professor Mashodo Tashifularo from University of Pretoria in South Africa to present the 10-year review of cholesteatoma in a tertiary institution. So Dr. Professor Mashodo, you are most welcome to present your presentation, and Alexandra, please with him.
Share.
Dr. Mashodo, Professor Mashodo.
Just
Do you hear me?
I see you've disabled us to share the slides. Can the technician able us?
Dear Alexandra, please guide Professor Mashodo.
Yes, Dr. Mashodo. I'll make a host now.
Yes. Yeah. Share. Can you see the slides?
Yes, Dr. Mashodo. Kindly proceed.
We can see the slide.
Good morning, ladies and gentlemen, and thank you so much for the invite again to the Egyptian Society of Otorhinolaryngology. I really appreciate.
It's narrated.
Yes.
Share our experience with cholesteatoma. The one of my registrar did, Dr. Sirwalo, and I'll be present this morning. We know that there will be a lot of consensus statement, and the agreement, universal agreement for classification, at around 3% by your mature staging system for the middle year. And,
Yeah, Alexandra.
Dr. Mashodo,
is busy.
hope you have received our screenshot. You just click that button to enlarge your screen and proceed your presentation.
the classification that we use.
Dr. Mashodo, can you hear me?
Yes.
Yes, that's right. Can you please?
I must start.
Can you please click on that button which I have shown and which I've sent you through email? Yes, that's right.
Can you hear the recorded one?
A lot of
It's not audible. It's little bit low from your side. Can you raise the volume or adjust the volume?
You all know what is cholesterol,
No,
and, but the pathophysiology of cholesterol.
It's a recorded. Alexandra, is it?
Yes, doctor.
Okay.
He might be
Okay.
recording.
let's see if it is recorded. Let's see.
Dr. Mashodo, it's not audible to all. Can you please
It's not
recheck
audible.
the audio? Yes. Can you please recheck the audio?
Okay, remove the audio. Remove the audio.
You all know.
Okay, we are removing the audio. Can you see us now?
Yes, Dr. Mashodo. I can see
Okay, good.
Yes, I can see your slide.
I've removed the recording.
Okay, instead of that, you can present.
Yeah, let me talk and then we'll hear if you can hear me well. Thank you so much again for the invite. And I'm presenting a study which was done by one of my registrar. So this is part of the dissertation that I said it will be interesting to present on the prevalence and presentation of cholesteatoma in the era of HIV and AIDS at the Biko Academic Hospital. You're well aware that HIV and AIDS has always been a big problem in this part of the country, including our university. We did a study some years back, which we published. Fortunately, it has become like a chronic disease. So a patient, even when they have cholesteatoma, when they have HIV and cholesteatoma, it does not make much difference, but it has some very interesting findings that we'd like to share with you today. We know that the definition and the consensus on cholesteatoma, there are many consensus from IONO, JOS, Joint Consensus Statement of what cholesteatoma is all about, and also the European Academy of Neuro-Otology. They published this statement before, and of course the definition was accepted by almost 90% of all the people who participated. So we are really not going to discuss that. But we'll be using the same definition for us, that cholesteatoma is a mass formed by keratinizing squamous epithelium in the tympanic cavity, mastoid, and subepithelial connective tissue, and by the progressive accumulation of keratin debris with or without surrounding inflammatory reaction. This is very, very important for us in view of HIV, because we found a lot of patients who presented with granulation tissue and discharging an infected ear canal, but we thought they were cholesteatoma to an extent that we had to come with a definition called a true cholesteatoma and a false cholesteatoma. We used STEM classification, which we found that it was easier for us to follow, which was involving mainly the tympanic membrane, the mastoid, the attic, and also some area which were difficult to access than using the other classification. Can you see the slide?
No, we don't see the slides. Only one slide, the first slide didn't move.
Yes. Please kindly follow your slides to move on.
Now, can you see the slide?
It's still the same one, the first one.
It's still the same one. Patricia,
Still, it is in your first slide itself.
Okay, with 2 slides here. Okay, we're sorting it out now. It was, because it was recorded, it was automatic. Okay, thanks. You can see the slide.
Yes, yes, Dr. Mashudu, I can see.
Okay, now the second one. You can see the second one, the definition.
Yes, yes, now we can see it. Thank you.
Okay, okay, thanks. We'll say that the definition of cholesteatoma is still the same one, that is a keratinizing squamous epithelium, which can be in the tympanic cavity or mastoid, and with a subepithelial connective tissue, and by progressive accumulation of keratin debris with or without